Okay, so Jeff Dugas, and I'm here to talk to you about what we do with OCDs in a gymnast. I want to say first, I agree completely with everything Mark just said. That's a great presentation, and especially if those uncontained defects, I treat them all exactly as he said. Um, there we go. So I'm going to start with a 12-year-old gymnast. This is a left-hand dominant gymnast cheerleader with a 6 to 8 month history of pain, intermittent swelling, denies a single injury other than a locking episode several weeks ago. No other elbow history, and reports she's unable to do gymnastics activities secondary to pain. So on inspection, she had a normal carrying angle, which I would caution you in some of these gymnasts and tumblers. They tend to have a little bit of a higher carrying angle because of all the weight bearing flying stuff they do, the aerial type of activities. They do tend to get a little bit more valgus alignment. She had a loss of motion, but full pronation, supination, and pain with the extremes, pain to palpation laterally, but good strength otherwise and neurovascularly intact as you'd expect. So this was her original x-ray, and you can see the obvious OCD lesion. This is one of the most important things about this, as Mark said, is the difference between a contained and an uncontained defect. The outcomes definitely are different between those, and that needs to be picked up early on. So this was the MRI that was sent to me, and you can see there's about a 1 centimeter defect where a loose body has gotten loose and is loose in the joint. So this is a contained, what appears to be a contained, isolated 1 centimeter or less OCD in a 12-year-old gymnast. So with the fragment already loose in the elbow, I did not feel there was any benefit to non-surgical management. However, if she was less symptomatic, or if there was something that was life important, like a state championship or a scholarship on the line, if she wanted to complete her season, I would certainly consider doing this at the end of the season and not push her into, immediate surgery. And then the role of biologics, and I want to touch on this in a minute. So we did elbow arthroscopy, took the loose body out, and debrided the OCD. And I use BMAC for these. This is one of the few cases that I actually think I talk people into using BMAC. I don't think I do that with any other case except for these. And I'll get back to that in a second. I put them in a brace for 6 weeks, and I let them get their range of motion back. We don't let them do any weight bearing, no pressing, no pushing, and then a gradual return to strength through a plyometric program. We start with two-handed plyos and then move on to one-handed plyos, light strengthening, and then functional activities. And I generally will let the gymnasts go back at 6 months post-op. No real difference in a 17-year-old, which is what I was charged to talk about. A little less likely to heal than a 12-year-old, but I think this is still young and healthy with good bone marrow. I like to use BMAC in these cases because of the theoretical advantage of improving the quality of the fibrocartilage repair tissue. There is an out-of-pocket expense, but in my opinion, this is the best chance to get this right without having to do a plug. And so this is a first pass at a contained defect. It's the same procedure. It doesn't change what I do surgically, but I do think that theoretically and then practically, I do think it improves the repair tissue. I hope to have some data on that to present within a couple of years. So this is just a brief arthroscopy video. A lot of times these things are still in the bed. This is one that was still in the bed, and I have to pop this piece up. So you take a small probe. Again, we're using 2 small portals on the lateral side, as Mark said. This is a perfect spot to get to the capitellum. These things are usually easy to find the border. Use a dull probe. I would not use a sharp instrument to do this. And I can usually get a small Schlesinger grasper in there to take this piece out. A lot of times you're going to take it out in fragments. It may not always come out in one single piece, but we're going to be able to get this piece out and then get a small shaver in that defect to debride the soft tissue from the bed as well as around the edges to make sure we get all of the loose cartilage out. We want to debride this back to a stable rim. This is a small 3.0 millimeter shaver, easy to get into that lateral side. These portals are about 2 centimeters apart. So you're playing chopsticks a little bit, but you can do all this through 2 small portals on the lateral side. You can see you get a bleeding bed in there. You can turn the flow off and keep suction on and make sure you get down to a bleeding surface. I'll then use a microfracture pick or a power pick to get access to the bone marrow and really get a couple of good holes in there and let that fill in. And then I stick a needle in the end in there so I know I get the BMAC into the joint where I want it. So portal placement is key. You have to be able to get 2 instruments in the lateral compartment. I use a smaller scope here. I usually use the 2.7 millimeter scope, the short one, rather than the long one. I get the fragment out first. Again, often have to use a probe. Shave and remove. Make sure you do a full debridement of this to get a good bleeding surface. I access the bone marrow, and then I put in the BMAC. and close the portals tightly. I'm cautious to tell the fellows, we always close the portals tightly. I want to keep as much of that in there as I can. So thank you very much. That's my plan for a contained OCD in a young athlete.